We are here with Professor Robin Hanson, an economist at GMU, George Mason University. Robin, welcome to the External Medicine Podcast.
Thanks for having me.
Before we get started, do you have any financial disclosures?
More money, please. That's just in case anybody was ambiguous about that. If you're thinking, could I send him money, but maybe he wouldn't like it? Guess what? No problem.
Excellent. So we're going to talk a little bit about your background. I'm assuming that most of our audience should be at least a little bit familiar with who you are. But for those who aren't,
I doubt it.
How would you describe your general background and your intellectual interests?
Well, I'm a tenured professor, which is very lucky for me because it means I get to spend a lot of time thinking. I squeaked by to manage to get that. I didn't focus as much as I should have as an academic, but I am more of a polymath who just likes to think about a lot of things, collected a lot of intellectual tools over the decades, which I can now combine together opportunistically to produce novel insight.
Well, amongst those novel insights, you've written a lot about healthcare. How did you get interested in writing about healthcare? And maybe set up some of the reason that you ended up writing The Elephant in the Brain, which we'll talk about shortly.
So I got my PhD in 1997 from Caltech after a 4-year graduate program. And I applied for jobs. And the job I managed to get was a health policy postdoc at UC Berkeley, where I was interdisciplinary, where I worked with political scientists and sociologists and economists all together. And that was my introduction. So I had just previously learned relatively abstract economics, and this was my opportunity to learn about this particular industry in detail. And I discovered that it was actually quite at odds with the abstract description. So there's just a lot of weird stuff in health and medicine that I didn't anticipate, and that struck me as in need of explanation. So that was my introduction to health and medicine, this 2-year health policy postdoc. I tried to think about how to explain these puzzles. I came up with a simple signaling story to address many of these puzzles. And once I was willing to accept that unusual explanation for that unusual industry, I was more willing to consider similar explanations to make sense of other industries and other kinds of human behavior. And that over decades led to The Elephant in the Brain, which is an attempt to explain a lot of different weird things about humans, basically using similar explanations to the one I came up with to make sense of medicine back in 1997 to 1999.
You said that the things that you encountered when you were doing your postdoc at Berkeley differed from what you had learned about abstractly doing your PhD. What was it at the time that struck you as being most divergent?
Well, the usual abstract story about medicine that most economists just assume, because it's what most everybody believes and it makes sense, is, well, you can get sick sometimes or injured or, not fully healthy. And then there are these experts, doctors like you guys, who are helpful at that. But these doctors are expensive and their quality might be difficult to judge. And therefore, that's why we need insurance to pay for this rare, expensive thing. And that's why we need, say, regulation to tell us which one of you guys are good. And, most of the rest of economic analysis of medicine proceeds from there. And the first thing I noticed in medicine was just there seems to be almost no correlation between health and medicine. The story is that medicine is about improving your health, and there's not an obvious relationship there. That's one puzzle. And then another puzzle is just people are really eager to regulate medicine in a great many ways. They're eager to sort of have it be supplied communally. And compared to other kinds of health influences, people are really obsessed with medicine and not really very interested in the other apparently much larger influences on health, like nutrition and sleep and air quality and, exercise and things like that. That's also strangely puzzling. So once you realize that medicine seems to have a pretty weak influence and other things have a much stronger influence, you might think, well, we should turn our attention to those other influences. but we don't.
So let's talk about some of those studies which correlate health and medicine. As far as I'm aware, there are only 3 randomized control trials, the RAND experiment, the Oregon Health Insurance Experiment, and the Karnataka experiment in India. Can we, maybe before we talk about those, can you just describe other studies, retrospective studies that have been done, and then we can go into the details about the actual randomized control trials?
So obviously, there's this vast medical literature, much of which consists of evaluations of particular treatments. So, a typical study will have some particular class of patients who have a particular condition, and it will consider some particular treatment or two. And it will typically come up with a positive evaluation that that treatment is helping with that condition. And there are millions of these papers, literally millions. So we got to count that as part of our evidence, right? So that would lead you to expect, well, if we try to aggregate all that things, if we try to look overall at medicine, not just one particular treatment, but all the medical treatment a person could get, say from a particular medical insurance plan or something, that adding that all up, we would also see an effect where if they got more of all those things, they would do better. That would be the obvious expectation from all those millions of studies. And initially, people looked at correlations. They looked at, say, US counties or hospital service areas that have more medical treatment done on people in general or people in a certain age and, condition. And those sort of studies initially tended to just not find any effect. After you'd control for things like wealth and age and other sorts of things, the coefficient on medicine would just not be there. Now, people have done a lot of these studies, and as you may know in terms of statistics, if you try hard enough, you can always find whatever effect you're looking for. And people have found effects of the form of the coefficient that suggests more medicine is healthier. But the question is, how hard do they try? That is, how many knobs do they turn somewhat illicitly in order to get this apparent effect that there's a medicine health correlation? My reading is that, like, most of the initial studies found no effect, and most of the studies I've just seen, like, without an axe to grind, seem to find no effect. But yes, there are people who find effects out there, and it's harder to judge. That's why you would try to go to the most solid sort of studies, like the randomized experiments, you might say, given that there's all these, the usual studies find nothing. Some people find something, but they might be trying really hard to do that. Let's go with the studies that would be hardest to manipulate, where there's just fewer knobs to turn. It's all set up to just get a certain result a certain way, and you just look at that result. And so randomized experiments are, in a sense, our ideal version of that, right? You take a group, two groups, you try to keep them as similar as possible, except that you have one get more medicine than the other, and then you track health for the two groups. And you don't let people coming back and say, oh, but if you do a regression, you throw these things in, looks like you see an effect. You go, no. That's not the game we were going to play. We were going to take these two groups and we were going to see what happens, right? And so those are the more rare and more expensive treatments. And of course, we're talking about aggregate treatments. So like we said, there's millions of studies out there of individual treatments. Some of those are randomized. But we're wondering what happens when you just take medicine as a whole, all together, and you just have a way to give some people more or less medicine. Now, we might ask, well, how are you going to give some people more? So in the geographic things, that some people live in areas where they get more, and you might wonder, well, those areas could be different in a bunch of ways. Maybe you can't tell. So, we have more trust in a randomized thing where we're going to randomly give some people more medicine. But you say, well, how do you randomly give some people more medicine overall? And a simple favorite way is price. You just offer some people a lower price. And turns out at a lower price, they get more. And that's just a nice random control because it seems like, we're not going to be selecting for certain kinds of patients over others very much and just lowering the price. That should just bring in most everybody likes lower price. That liking a lower price isn't something that varies in complicated, intricate ways that correlates with other things here, right? Just everybody likes a lower price. And for a lower price, everybody is enticed to get more. So that's where we get to these randomized trials. And of course, the biggest problem with randomized trials is you'd like them to be bigger. So sometimes you get like a particular, I don't know, heart treatment sort of thing. You can get really huge data sets because there's really big funders out there really, funding heart treatments, and they are willing to pay for this enormous trial. And you can get hundreds of thousands or millions of people in a trial, and you can get really good statistics. But when it's come to the overall value of medicine, people haven't been willing to pony up that much. And in some sense, it's expensive. You're not just paying for one particular treatment for one thing. You're paying for the whole package of all the medicine they're getting in a year. And so that's going to cost you more. But as you say, we have at least 3 of them. I don't know if there are more. I mean, I can't give you very much confidence, but say there's at least 3. And the key point is these are randomized trials. We randomly give some people a lower price than others. And, we have maybe at least thousands of people in the trial. So you should at least think these trials are better than your intuition. Like if you're saying, but my uncle and I know this other guy, you got to know that, like, okay, your data set is just not going to be as good as this. Even if it only has 5,000 people in it, it's a lot better than all the people right? So you got to go with that. And then, the question is, okay, it only has so many people. How strong a conclusion can we draw? So the first one was the Rand Health Insurance Experiment. It had roughly 5,000 adults and over 3 to 5 years. And that's actually not enough to use mortality as an endpoint to tell the difference. It's just not enough people there for a long enough time. But they had 20 other measures of health. And so they could look at those. And the bottom line was, looking at those, you're not really seeing an overall effect. Now, what you expect is that if you've got 20 measures and you have a 5% significance level, guess what? On average, one of them will look 5% significant, even if there's nothing, because you looked at 20 things, right? So that would be the standard here. I'd say relative to that standard, you're not really seeing an effect there in the Rand Health Insurance Experiment. So one interesting thing we do know about the Rand experiment, though, is they did this exercise where they had doctors read medical records of cases in the 2 arms of the experiment. I mean, they had multiple arms, but we were splitting it into 2. And they had these doctors judge the severity of diagnosis and the appropriateness of treatment in those cases, so they could ask, were the cases that were getting, were the arm of the experiment where they were getting more medical treatment, was that extra treatment less appropriate, and was it less severe diagnosis? So that could be one story you see, is that, yes, they got more medicine, but it was not for relatively mild cases, marginal cases, and maybe less appropriate treatment because they were spendthrifts. The doctors were being sloppy and doing too many extra, not very well, thought out things. And the story was, there's no connection here. The arm of the experiment where they did more, roughly 30-40% more because they had free medicine, those medical records were not more severe of diagnosis or less severe diagnosis, nor less appropriate treatment.
And so the Rand experiment on healthcare was from 1974 to 1982, extremely expensive, $50 million. And the specific different groups that they were divided into were cost sharing amongst people who had totally free care and those that had to pay varying percentages of the cost. And there was also an HMO arm as well.
Right.
What were the specific endpoints that they were looking for? And who was it that was willing to put out $50 million for this study? I mean, this wasn't big pharma.
This was a US government thing. This was in the era when, talking early 70s, when there was a lot of optimism that we could convince the US public to spend a lot more on social spending. The only thing show was effective. So the presumption was, we just do this experiment, we show that this is effective, and then the public will say, yeah, we need to spend a lot more on this. And so they were quite a bit surprised to get the wrong answer. They also had a welfare experiment at the time where they tried to show that welfare was a good idea with the randomized experiment. They also got the wrong answer there. So it took the wind out of the sails of doing these experiments for a while because they paid for expensive experiments to get the answer they were supposed to get, and they got the wrong answer, and they didn't want to do that anymore.
So they took all of these different groups who are paying different amounts of their healthcare costs. It seems like there was between the people who were paying the least and the people who were paying almost all of their healthcare costs, there was about a 40%-ish, 30-40% difference between those. And then they were the endpoints that they looked at were things like blood pressure and dental care, vision, a bunch of other cholesterol, things like that. And essentially all of them ended up being no different between the people who were paying a lot and the people who were paying almost nothing. The people who were paying almost nothing used a lot more services, but didn't get any sort of aggregate benefit from spending more money, more of someone else's money. There were a few things that they found that were positive. One was vision. The vision was better in the people who didn't have to pay. And then hypertension was better controlled, which they said would amount to like a 10% mortality difference over a long time. Now, looking at the numbers myself, it was just a few percentage points difference in diastolic blood pressure and a few millimeters of mercury. I don't know how much we're willing to say that definitely would cause a 10% increase or decrease in mortality. But what is your overall response to these findings that they list?
So for vision, I'm willing to just say, look, that shouldn't be called medicine. Right? I mean, if you've got a hole in your window and we come fix your window, yeah, the rain's not coming through your window. We just have a very direct way to measuring the effectiveness of that. And we should just say, yeah, if people don't have eyeglasses and you pay for them, then they can see with eyeglasses. But I would just say that's just not indicative really of all the rest of medicine. The hypertension to me looks more like, well, if you look at 20 things out of 5% significance, you're going to find one of them. And so I can't take that seriously. In addition to these 20 more specific measures, they had some measures of just overall functioning. They had 4 of these measures, I think, of just overall, can you do what you want in your life? And it turned out they split that by people who were sort of initially healthy or initially unhealthy, I think. And what they found was pretty close to 5% significance, although not quite all the way there, of saying that people who were initially unhealthy and who got free medicine, they basically went wild saying, all right, I can finally get all these things tested and finally get all these things dealt with. And they looked like they were almost significantly less functional. It hurt. And then there's this other, relatively straightforward measurement of like, how many days did you have in the year when you could not do other stuff because you were dealing with the medical system, and that was like another day per person when you got more care. So those are relatively negative, but overall, I just say, no significant effect would be my overall reading. I mean, if you just have limited data, it's too dangerous to like go try to tease things out of it by searching for things. So I'm going to my overall judgment is going to be basically no effect.
So that's a very surprising finding. I assume that people who were conducting this study were not expecting it. And I think that it would be relatively easy for someone looking back at that now to say, well, that was, 1974 to 1982, beta blockers weren't in wide use. There have been a lot of developments since then. And also it's only a 3 to 5 year study. Like, maybe there are more recent data would be more beneficial. But then there was a randomized controlled trial on, I believe it was Medicaid patients in Oregon in 2008, randomizing patients to either get Medicaid or not. Can you tell us a little bit about that trial?
Well, the first thing to just notice is like we're spending over $2 trillion a year on medicine at the moment in the US. And so a $50 million trial is really a tiny investment. If you're really in doubt about the value of all that huge amount, like, and you saw this initial thing and it was bad, what you should do is like, okay, let's do another little bigger one and see if that, replicates. And so it's kind of telling that we didn't. And so this Medicaid study was not done in order to, figure out in general the general effect of medicine. This was just a policy that Oregon decided to implement where they had some money. They didn't have enough money for everybody, so they randomized it. They weren't randomizing in order to do this academic study. They were just randomizing in order to try to do something nice with a limited budget. So they randomized. So again, here we're looking at people who are especially poor and presumably on average less healthy. And we're giving some of them access to more medicine. And the main result of the study was that people were less depressed and less stressed by the prospect of getting money to cover medical expenses, which for this population is very expensive and stressful. And these benefits of less depression, less stress appeared before they got any treatment. That is, they learned that they were the lucky ones who were going to get in this better program. And right then, most of the benefit appeared. They went, calm down, less stressed, less depressed, because now they were going to get stuff paid for. And, I think that's completely plausible for any category of spending that you're planning on spending on. If it's uncertain and you might be at risk of having to spend a lot of money you don't have, that can be pretty stressful. And it could be very comforting not to have to spend that, to have somebody else pay for it. That doesn't say anything about the effectiveness of medicine. It says something about the effectiveness of giving people money when they are short of money. That's just obviously the sort of thing that would be comforting and calming and put you in a more healthy state of mind.
The finding here is very striking. I'm just going to read the conclusion from that trial, which was published in the New England Journal in 2013. So they had the 6,800 people in one arm getting Medicaid, the 5,000 or so, 5,500 in the other arm, not getting Medicaid. There was a random assignment between them. They looked at them over the course of 2 years, and here's the conclusion. We found no significant effect of Medicaid coverage on the prevalence or diagnosis of hypertension, high cholesterol levels, or the use of medications for these conditions. Medicaid coverage significantly increased the probability of a diagnosis of diabetes and the use of diabetes medication, but we observed no significant effect in the average glycosylated hemoglobin levels or the percentage of participants with levels of 6.5% or higher. Medicaid coverage decreased the probability of a positive screening for depression by about 9 percentage points and increased the use of many preventative services and nearly eliminated catastrophic out-of-pocket medical expenditures. So less depressed, but no, after a couple of years, they didn't find a real difference between the two groups. And again, you could be like, oh, it's only 2 years. It's just Oregon, but. And now there's the Karnataka experiment in India. What do we know about that experiment and what did it find?
So first of all, it's not in US or a rich country. It's in a poorer country. Now, some people, have differing intuitions about that. You might think, well, in a rich country, we're also rich. We're all getting lots of medicine. So maybe on the margin, medicine isn't so valuable. But in a poor country, you're not getting so much. So maybe medicine will have a higher marginal value. That's on the one hand. On the other hand, people say, oh, those people are corrupt and ineffective and they don't know what they're doing. And so, medicine there doesn't count for so much because that's bad medicine, right? But we can say, these were intermediate wealth people worldwide. For more of middle of the world level, if you want to predict medicine in the world, this is a better case than the US. And this is all population. We're not just looking at the poorest people or the sickest people or something here. This is the whole population of India. But a key point is this is only hospital medicine. So in some eyes, that's the most valuable medicine we give. Some eyes not, but this wasn't about just ordinary doctor visits. This was about going to the hospital. So this was a kind of insurance that you could get, which would pay for your going to the hospital. And some people basically got this cheaper. And so we're looking at the effect of being offered cheaper hospital insurance, which most people took. And this one, we have like 80,000 people. So we're looking at, maybe a factor of 20 times more people than the RAND experiment. So now we've got better stats, right? So if there's a small effect we couldn't see before, we can see it here. Here we're looking at death and a bunch of other measures again, if I recall. And I mean, just to say, I didn't actually do any research just before we started to talk here. I haven't looked at this stuff in a couple of years, really. So I'm doing all this off the top of my head, but tell me if I get anything wrong. Basically, there was no observed effect across a whole bunch of measures for these 80,000 people on getting offered cheaper hospital insurance. Now, of course, most people don't use hospital insurance in any one year. But, that was true before on the other experiments. Most people don't use the extreme versions of medicine in any one year. And so now we're going to say that in India, with 80,000 people over, like, was it 5 years or something like that? It was 4 or 5 years. No effect on the health measures they set up.
Yeah, I'm just going to read the abstract because it summarizes. Yeah, you summarized it beautifully. But just to give a couple of numbers, we report. This is from the abstract from 2021. We report on a large randomized controlled trial of hospital insurance for above poverty line Indian households. Households were assigned to free insurance, sale of insurance, sale plus, basically a bunch of different options and a control. And the opportunity to purchase insurance led to 60% uptake and access to free insurance to 80% uptake. So increased amount of usage, access to increased insurance utilization increased. And across, here's the punchline, I think. Across a wide range of health measures, we estimate no significant impacts on health. Yeah.
One thing to notice here is there's an asymmetry in the attention to detail and passion on topics like this. So, like, think of 9/11 truthers or something, right? If you meet a 9/11 truther, they're going to know the details of all the buildings, what happened when, and which studies were done, and what metals were there, and what temperatures they found, and all that sort of stuff, right? And they're going to bury you in all those details. And if you're a 9/11 truther skeptic, you're not going to be spending that much time learning all those details. You're going to look at some overall stuff and going, what the hell, this doesn't make any sense, and just walk away, right? But, this is true across a lot of topics. There's just people who are really passionate and into something and pro on one side, and they just really get into, and they know lots of details. And then there's other people who sort of get down on it, and then they know some general stuff, and they may draw some conclusions, and then they kind of drift away and do other things because they're not so obsessed with it, right? So that's how I am kind of more on medicine here. I spent some time learning the economics of medicine and modeling it and thinking about it, but then I took those lessons and went on to build that with other lessons and to do other things. So that's just going to be an asymmetry that everybody should expect about this sort of topic. Like, people who are really pro-medicine, they're willing to make that their life. Medicine is their life, it's their cause, and they want to do study after study, and they're going to know all the details, and they're always going to say, yeah, but what about this other thing? Just like the 9/11 truthers would, right? And that's just kind of how you have to expect this to go. So here I am, I'm basically saying, okay, I looked at some of the correlation studies, most didn't, I didn't see an effect, some did. And then I say, okay, I looked at the strongest experiments, and I say, yep, those are not finding anything here. And I'll bet somebody who's on the other side, who's like their whole career is wrapped up to this, they'll come up with, yeah, but they'll have exceptions and other considerations we should bring into each one of these things and try to say it's not as simple as you're saying, right? Just like the 9/11 truthers would. But that's how these games go, okay? So, from my point of view, I go, this is enough. This is enough for me to draw my conclusion. And then I want to know, like, how do I interpret this? How can I change my worldview to assimilate this? How do I understand this and understand humanity and the world as a result? And this makes me less interested in diving into all the detailed variations, European medicine versus American versus Chinese versus, internal versus external medicine versus preventative versus, there's all these distinctions you could make and all these things you could go into, and I can't be bothered. Sorry. because the whole thing is just not very effective. I mainly want to know, why are people so obsessed with this stuff if it's not very effective? That seems to be the interesting thing. How are they thinking about this? And what lessons can we learn from that?
That is an excellent segue into The Elephant in the Brain book that you co-authored in, was it 2016?
Yes.
2016. So in The Elephant in the Brain, you explore the hidden motives behind behaviors, including those in the healthcare system. One quote from the book is, "Medicine is, in part, an elaborate adult version of Kiss the Boo Boo." What did you mean when you wrote that?
Well, I wrote it with a co-author, so those words were probably my co-author's original words, but yes, they're mine too now that I'm a co-author. So the idea is that medicine functions to a large degree to let us show that we care about each other. So think of an evolutionary psychology story. Our distant ancestors, the main thing they cared about was each other and being on good terms with each other. And one of the things they needed to do was show each other that they cared about each other. One way to do that is like how we do at the office. You stop by, everybody's desk in the morning saying, how was the game? How was the show? Whatever. You chat for a little bit and then you go on. And that's a way we show that we care about each other. But it feels shallow in the sense that, like, if they were about to betray you, they do that the day before. And then all of a sudden, boom, you'd be betrayed, right? So what humans are really interested in is signals of long-term commitment to each other. Like, what will you do that will show me that you're with me for the long run? And unfortunately, the best signals of long-term commitment are going to be when rare things happen to you. In some sense, like if you get injured or sick, if I was kind of on the margin of sticking with you, that would be the good time to dump you. Because all of a sudden you're going to be expensive. And maybe I don't want to pay for that, right? But if I go out of my way to pay for it anyway, that's my signal. I'm saying to you, I expect you to be valuable for the long run here. Yeah, you're sick and injured, and it's going to be a bunch of pain to deal with you for the next few weeks or whatever, but you're a good investment. And I'm going to invest in you for that reason, to make sure you're around and to show you that I care about you and show everybody else I care about you. And that's really emotionally potent. If you've ever known in a situation like that, you know that when somebody goes out of their way to show you, I care about you, this is exactly the right time to dump you, but I'm not dumping you, I'm going to take care of you. That just really touches you. As well it should, because it's this really potent emotional signal, ancient signal of that somebody cares. And so in some sense, medicine is an ideal way to show that you care about people because it's this rare thing that you have to spend a lot on. You'd only do that if you really wanted somebody for the long run. And it works. So, for our very distant ancestors, the main thing they did while you were sick was just bring you food and keep predators away from you, keep you warm. And it couldn't do that much else for you. Maybe hire a shaman, extra expensive, to come do something for you. But, they were just trying to spend money on you. So the idea here is that as we get richer, you got to spend more to show you care, right? It's got to hurt. It's got to be painful in terms of how much it costs, time and effort. And so we evolved this habit of using medicine to show that we care. And the main thing that we were trying to show is how much we're willing to suffer and pay to convince somebody that we really cared about them. And as we get rich, we got to pay more, not just proportionally, even disproportionately more. That is, so, one way to think about it, in our ancestors in good times or bad times, in good times, they want to invest in things that will be useful in bad times. And one of the main things you can invest in good times that's useful in bad times is associates, allies. So that's an explanation for why, this investment in showing allies you care about them would be a luxury good. Basically, when you're richer, you spend a larger fraction of your income on it, because it's one of the few things you can do in good times that'll be helpful in bad times, is to invest in allies. So the idea is humans evolved this habit of treating medicine as a way to show we care. And it was not so much about how effective it was more about how much you paid, how much effort you put in. It was a luxury good in the sense that it's the sort of thing you spend more on when you're richer, because that's a good time. And it's not just that you want to show other people that you care about them. You want other people to be able to show they care about you. You want the world to see that you have allies and that people care about you. And so an analogy that we give in the book is Valentine's chocolate. We have this habit on Valentine's Day of giving people chocolate. And when you decide how much chocolate to give someone, you don't ask how hungry they are. You ask, how much do you have to spend to show that you care more than somebody else who wouldn't be willing to spend that much. And when you think about the quality of the chocolate, you don't really care about your and their private opinion about the quality. You care about shared judgments of quality. What does everybody tend to think is the good chocolate? And if you don't have anybody to give you chocolate on Valentine's Day, you might want to buy yourself some chocolate and leave it on the desk at work. Why? Because you want everybody to see that somebody cares for you in the same way that everybody gets cared for. So the medical analogies are, we spend enough medicine so that we spend a lot, and it doesn't that much matter how effective it is on the margin. We're not very attentive to the quality of medicine in terms of private signals. We care about what generally accepted as quality signals of medicine. And if somebody else won't buy it for us, we got to buy it for ourselves so that we seem cared for.
One of the historical public figures that you and your co-author quote in the book comes from England's King Charles II, who fell ill in February of 1685. And you have a quote here of what the physicians treating the king released publicly in order to demonstrate how much effort they put into trying to save the king. They wrote, after a pint and a half of blood was drawn, His Royal Majesty was forced to swallow antimony, a toxic metal. He vomited and was given a series of enemas. His hair was shaved off, and he had blistering agents applied to the scalp to drive any bad humors downward. Plasters of chemical irritants, including pigeon droppings, were applied to the soles of the royal feet to attract the falling humors. Another 10 ounces of blood was drawn. The king was given white sugar candy to cheer him up, then prodded with a red-hot poker. He was then given 40 drops of ooze from, quote, the skull of a man that was never buried, end quote, who it was promised had died a most violent death. Finally, crushed stones from the intestines of a goat from East India was forced down the royal throat. And unsurprisingly, 4 days later, the King Charles II died.
Aren't you jealous? I mean, none of us have been treated with such elaborate, expensive treatments, I'm betting, right? Your family clearly doesn't care about you as much as that king's family cared about him, right?
Yeah, the term that you use in your book is conspicuous caring hypothesis. And I want to kind of pull that out a little bit and get into some of the details of, private versus public signals for health. And you could just elaborate on how, if we buy this assumption that you're right, that this explains why we spend so much on health without getting an effect and maybe not even needing an effect, what are the implications of that?
So one thing to get clear about is what kind of an explanation are we talking about? So you could imagine an explanation in terms of your thoughts when you do something. You could say, well, when you do something, just before it, you have some thoughts. And so if we can predict the thoughts you have, maybe that will predict what you do. And that's a way to explain what you do. To explain your thoughts. That's at one extreme of having a very proximate explanation to a phenomena. You're looking at explaining the most nearest cause to it. But we could also have distal explanations. So that is, we can look at larger social forces, overall processes that would tend to cause something, even if they wouldn't do it through such a simple way of having you have a conscious thought to do something. So Elephant in the Brain is mostly focused on these distal sort of explanations. It's not telling you what your thoughts are. It's saying there's large social forces that are going to, on average, push you to do certain things. They have a lot of intermediate paths by which they can do that, most of which you're not consciously aware of. Nevertheless, the world is competitive and complicated, and on average, these various distal forces, they get their way. Like you need food to eat. So a distal explanation for eating is well, this nutritional need to have food to eat. Now, at the moment you eat something, maybe you thought of the food a moment ago, maybe you had some free time to get it, maybe it's within your budget, right? But there's this more basic explanation. You got to have food to eat and to survive. So you're going to get food on average, and it's going to have some calories, and it's going to have some other things you need. Otherwise, you don't last, right? And so that's what we're doing here in terms of explaining medicine. We're saying, you're thinking in terms of medicine, in all sorts of complicated ways, and we're not trying to capture all that. We're trying to talk about, why is this thing happening? So for distal explanations, it's sufficient to look at overall patterns. Ask of, who does this more often than who? What sort of things do people say in general about this? How different societies varied in how they treated this. Those are the overall patterns that you're trying to explain with your distal explanation. So one of those is this lack of effectiveness of medicine. That's a striking pattern. And it's not a pattern that's sitting in people's heads when they're thinking about choosing medicine, right? So that we're explaining that through this overall signaling intuition instance, but we're not telling you how exactly that changes your thoughts. And people think about medicine quite differently, actually, in different societies and times in terms of their conscious thoughts. But still, there's this overall function that we'd say. I mean, the key point might be, if at some point you have an associate who's sick and you say, not much we can do. I could use this money for other reasons. Sorry, guy. That's the end. Basically, that guy's going to look at you a little funny. Your friends are going to look at you a little funny. Your family is going to look at you a little funny. They're going to think a little worse of you. And when you consider taking that option, you're going to kind of know that. You're going to know, I give up on dad or grandpa or whoever and save the money and use it for a new cow or whatever I'm going to need money for. Other people are not going to take that so well. And that's an important social force on your behavior. That is, we anticipate how things will make us look, and we try to avoid doing things that make us look really bad.
Yeah, this reminds me a lot of the in the intensive care unit, a lot of the discussions with family about end of life care, when they don't go the way that the physicians on the team are intending. You have a patient who's extremely sick, who's moribund. I'm thinking of one patient who had metastatic cancer, had lost like 50 pounds of weight, and was clearly at end of life. And family member insisted that we do everything, even after being explained multiple times by different physicians that, even if he's able to live for a day or two longer, the prospects aren't great. But just the idea of not being able to care for him and to show her caring for him leads us to just waste tons of resources on I wouldn't even call it helping a patient, on prolonging the agony of a patient who there is no modern medical way to actually, unfortunately, to resolve the underlying disease.
And let's just call it torture. I mean, it is less pleasant to get all these end-of-life treatments. It's not as comfortable. It's not as pleasant, right? You're basically taking these people and torturing them in the name of showing them that you care and want everything to be done for them. This might be, in a sense, the most common form of torture in our world: direct physical torture. And we do it out of love.
I think the explanation that I've heard with patients and patients' family members, it's usually the family members in that situation, is we want God to know that we did everything that we could. It's usually some type of religious or religion adjacent concern. And I guess I'm sort of curious, with all of your work on near and far mode of thinking, how that comports.
I mean, my dad was a preacher. My brother is a preacher. My mom wrote lots of Christian tween novels. They were missionaries together. I think I know enough about Christian texts and theology to know that God doesn't tell people to do everything possible. When there's not a scripture for that. It doesn't say, never give up on somebody and make them always be in pain no matter what. I mean, they're using religion as an excuse there, but that's not really the driving force, I would say. I mean, the driving force is more that, they feel in some sense, that they're being expected to show how much they care. That is, this decision is going to be framed in terms of how much they care. And they don't want to be the sort of person who doesn't care. So that's why they choose the caring, torturing choice. Since I wrote Elephant in the Brain over the last year, I've done a lot of work on the sacred, the concept of the sacred, and trying to understand that better. And medicine is in our society sacred. And religion is too, and religion's on the decline, but medicine is on the increase as a sacred thing. So I think that's another contribution here. That is, one of the norms of the sacred is that you just don't mix the sacred and the not sacred. And sacred is just a uniform thing that you do it or you don't, and it's either right or it's wrong. And so a great many people deal with the stress of medical choices by just basically saying, medicine is sacred. I'm just going to do medicine. I am just pro-medicine. That's just my stance. And I'm not going to make trade-offs on the margin. And I'm not going to choose to question my doctors or whoever else. I'm just going to make a simple choice according to a simple moral rule. And if I believe in medicine, the simple rule is always do as much as you can. That's the way they show respect to the sacred thing of medicine, is by basically saying, I want all of it. Now, a different way they could treat medicine as sacred is say, I will just believe these doctors and do whatever they say. And some people do that. That's often a way that people deal with medical stress when it's not such an extreme case. Maybe more for themselves. But when it comes down to somebody else, I think there's this question, do you care enough? Are you willing to sacrifice enough? And framed that way, it's just always do more.
Self-deception is a big thread running through the elephant in the brain. And so just to get very granular here, what you're saying is that this person, this family member whose family member is dying, the patient is dying, the family member is there, they believe that they are doing this because they truly care about this person. I think if you ask anyone,
right,
Mitch's patient in the ICU, the family member there is saying, we want to do everything. They're saying it's because I care. It's because I deeply care about my mother, father, grandfather, whatever. But actually, what you're saying, what's actually going on, according to you, is that this is a long evolutionary signal developed over a long period of time in which we signal to the people around us that we are the sort of person who will do a lot to benefit the people around us. And that's really what's going on. It's obviously a controversial claim, maybe a disturbing claim, because it sort of speaks to human beings as being fundamentally selfish in a certain way. But that's your analysis of the patient in the ICU and the family member saying, let's do everything.
So remarkably, this is one of the least selfish motives that we discuss in our book, The Elephant in the Brain. That is, what you're doing is showing that you care, but that's because you actually care. That is, you can't successfully show X unless X is true. So you're going out of your way to pay a cost to show an X here that is true. You are willing to pay high costs for your associates. And you are truly showing that. And that is a truly admirable thing that we see as admirable and that we want in our associates. It's just not having the effect you think it is of saving this person's life or having them be in less pain, unfortunately, but you are in fact showing an admirable, non-selfish feature of yourself. So the more the idea is we evolved behaviors over, millennia and many generations, consistent human behaviors that work. And evolutionary pressures, i.e. selection pressures, like some societies, people win more and succeed more if they do them, those are powerful over the long run and they can shape behavior. And they don't have to go through the medium of your mind rationalizing why you do things. Your mind is capable of coming up with reasons for all sorts of stupid things. And your mind isn't that good at figuring out what the best thing to do is. But for a lot of your decisions, you're not actually listening to these reasons in your mind. You're copying what other people around you do and doing what everybody's always done and what you feel emotionally inclined to do. And that's where a lot of your behavior comes from. You're part of a, species with a long tradition, long evolved habits, and part of societies that teach you from an early age what we do here and how things are done. So, whenever you do anything, your mind is ready with an excuse and an explanation for why you're doing it. But a lot of that is post hoc explanation, justification. You rationalize what you're doing. You don't really know why you're doing a lot of what you're doing, but you know that you do it and you know that you want to do it. And if somebody asks, you've got a story. So right there, that should make you wonder, how much do I know about what I do and why? Because you know that you have all these explanations, and you also should know, if you think about it, if we start to press you on these explanations, they don't hold together very well. You've probably experienced that before. So the story here is, the self-deception is mostly in your rationalization of what you're doing, but what you're doing makes sense. It's a sensible, useful thing to do. It's there for a reason. It's evolved for a reason. It has some unfortunate consequences that you're maybe not willing to admit. But in some sense, this is less about self-deception driving behavior, more about self-deception excusing behavior, explaining. You ask you why you do that, you come up with something.
So in the earlier portion of our discussion, we laid out 3 different trials that essentially showed that more medicine doesn't actually lead to better health outcomes. And in this discussion of the book that you co-authored, you put forward the claim that these hidden motives underlie a lot of human behaviors, and in the case of healthcare, the need to demonstrate caring for others and feeling cared for leads to, at least in the case of healthcare, a lot of waste of money. And we could, in other ways, better achieve the ends of longevity, better health, by designing better healthcare systems. That's sort of I don't think that you necessarily articulate that explicitly, but that's sort of the subtext there. In terms of where you would focus attention or how you would go about designing a more efficacious system for healthcare to actually meet the ends that we're seeking, like would you approach that through public health efforts, through vaccines, through reducing air quality, or improving air quality? Where would you go about actually trying to improve human health?
So there's an easy thing to do and a hard thing to do. Both of them face a common obstacle, which is you have to make people willing to adopt these changes. So at the moment, we subsidize medicine. And we should probably not do that for our collective benefit. And in fact, maybe we should tax it. But we're not only focused on our individual signal of how much we individually care, we're also focused on a society level signal. How does our society look to other societies? And so often we subsidize good looking things in order to make us look good to them. So I think US citizens are really quite proud of the fact that we spend more on medicine than the rest of the world does. And we think we deserve credit for, say, creating modern medicine and sharing it with the world, and that we drive most medical innovation. And that is a source of deep pride and, an ability to look down on other people that Americans like to have. So Americans would have to admit that this wonderful gift they've been giving the world isn't worth quite as much as they pretend, in order to be willing to cut the subsidies and actually tax the stuff that isn't actually that useful. So that's a very simple policy, but unfortunately, that's a problem. It faces that collective signal. And I think there's other things the United States spends excessive amounts on also to try to show the world that they should be more grateful to us, say the military. We have a story, we saved the world from the Nazis and the communists, and we did that by enormous military spending, and we continue with enormous military spending in part to remind the world, hey, you guys should be grateful to what we've done for you with all the spending. A more complicated thing would be to have more of a direct incentive contract for doctors like yourselves to give good care. So I think we would want to merge health insurance with life insurance and disability insurance, and even crank up the amounts of life and disability insurance in order to give our provider these incentives such that if bad things happen to us health-wise, they lose money. And if we can crank up those incentives high enough, then we can more back off and just trust them to make good choices, because they will have good financial incentives to make those choices. I think a major obstacle with this is that we treat doctors, in the US at least, as somewhat like sacred priests. And this is a way of distrusting them. And if you take doctors and you give them the strong financial incentive, that's basically saying, I don't believe you. I'm not going to just believe what you say. I'm going to, test what you say against this incentive. And that's an obstacle to all sorts of medical reforms. A great many promising medical reforms basically have you not trust your doctor so much. And to many people, that's one of the essential key strategies in medicine. They want to basically find an impressive, high-status doctor and then just trust them. And by trusting them, I think they feel like they are gaining status by association through that trusting relationship. And so that's a key way they deal with medicine. They're not going to think about the details. They're just going to pick somebody and trust them. And that shows their confidence in the sacred thing. And that means they're not so eager to do what would give doctors stronger financial incentives.
Let's move on now to another topic, which you have thought and written a lot about: prediction markets. You've even invented your own form of government based on prediction markets called futarchy, which runs on prediction markets. Can you explain to our audience what a prediction market is and how you got interested in them?
So let's take an example from medicine. We could have a drug, and some drug company wants to sell that drug and let doctors prescribe it to patients. And the FDA says, wait a minute, you need to do some trials to prove that it works. And that could take several years and a lot of money. And we could say, well, what if we have a betting market and we ask, what's the chance that this market will approve this drug if we go through all the tests? And we might say, look, if there's a 99% chance that this drug will go through the tests with flying colors, we should just let people use it now. And, and then we'll pay off the bettors after the tests are done. We could even do, what would be the chance that this drug would pass the test if we did a test, but only do the test 1 in 10 times? And if there's a 99% chance that we're going to pass this test, if we do this 1 in 10 chance of a test, we just let the drug be approved for use, and then, only 1 in 10 times actually even test it, thereby saving a factor of 10 in testing costs. So this would be an example of how we could use betting markets to make faster, cheaper medical decisions if we trusted the betting markets. So now you probably are asking, why should I trust betting markets? So a key thing to tell you is we have done dozens of trials over the decades where we've had a betting market on a topic at the same time we had something else on that topic. It might have been a committee, might have been a poll, some other mechanism to estimate the chances. And consistently, the betting market is as good or better than the other mechanism you might use. That's the reason you might trust it. That is, you put it head-to-head comparison with something else, and it does better, or at least as well. So that's a powerful engine that we could use to answer lots of questions in our world, because it's not that hard to set up a betting market. Now, there are some issues about how exactly to do it best and how much it costs or things like that, but this is the key argument. Basically, if you want to know the answer to something, and eventually we will know, and we want to know now before we would know some other way, then if we set up a betting market now, and we let that come to whatever market odds the speculators want, and then we pay off their bets later when we find out the other way, that turns out to be an effective way to estimate the chances of things. And we have some reasons we know why that seems to make sense, but you don't need to know these reasons or even believe them. All you need to know is this very consistently works. And this is now a machine we can use to answer various questions. So for example, say you have a project with a deadline and you wonder, will we make this deadline? You can just let people bet and they'll tell you the chance that the project will make the deadline. You might want to say you're a hospital and you're applying for grants, right? Applying for grants is a lot of work. And you want to know basically what are my chances with this grant? So you could have a betting market. You could let speculators see, here's 10 grants I was thinking of going for. For each one, tell me if I go for it, what are my chances? And then we can have a betting market on each one of those things where the speculators, if you go for it, if you choose that to be a grant you go for, then the bet's on and they get paid off based on whether or not you win the grant. So that would be a way to inform which grants you should go for. And we can think of a great many other applications here. We could do it for new hires, who to hire for the next set of people in radiology based on some employee evaluation after a couple of years. And so the argument here is this is a powerful mechanism we could use to answer lots of questions in society, questions about things that are stressful and disputed and important. We could just answer them this way.
What are previous examples of where prediction markets specifically have been successful or better than other alternatives?
So like I said, we have a couple of dozen trials where, for example, presidential elections, we have polls and other mechanisms of betting them, and we have betting markets on them. We have many corporate markets where they tried to estimate sales and project completion dates and other parameters for the corporation. An anecdote that might be compelling, perhaps. Once upon a time, there were two major competitors in the electronics business. One was Best Buy, a firm that's still around, and one is Circuit City, one that is no longer around. And in a key Christmas season, the Blu-ray player was introduced, as were Blu-ray discs to go with them, as was some other disc a machine called HD DVD. It was a competitor to Blu-ray. And these two machines were both on the market that year. And each electronics house like Best Buy or Circuit City had to decide which of these they were going to figure more prominently in their sales. They had to decide who was going to be the winner. At the time, Best Buy tried some prediction markets where lots of people in the company could bet on key things, one of which was which one's going to win out, Blu-ray or HD DVD. And the prediction market said Blu-ray would win. And so they went with Blu-ray, and Circuit City went with HD DVD, and Circuit City was gone in a year or two. They were on the fence and made a bad bet. So that's an example of how, if there's something you really want to know, then swallow your pride and set up the prediction market, and then maybe you'll get the answer and that'll give you a competitive advantage.
Just to clarify, it was Circuit City that went with Blu-ray, or Circuit City went with DVD?
Circuit City went with the HD DVD, which was the standard that lost, and Best Buy went with Blu-ray, which is the standard that won, in part on the basis of their prediction market telling them that that was going to be the popular thing. In part, they had sales people on the floor betting in these markets. So they weren't just getting some marketer's analysis, they were getting customer reactions.
So in the context of medicine, where do you see the lowest hanging fruit for successful prediction markets? Do you see it at the governmental level when it comes to policy, with pharmaceuticals, doing research, clinical trials, or setting guidelines? Where do you see it being most effective?
Well, you could perhaps give individual customers a prediction market about, say, their lifespan, depending on various key medical choices. That's a big ask, I think, of most customers, because, first of all, creating a market for each person is a lot more work than creating markets for these big aggregate choices. And again, medicine is sacred to people, and they're not so eager to take the advice of a bunch of random people, as they see it, who might be predicting these markets versus these prestigious experts like the doctors. So honestly, I would think that the first order of business is to get a player in the game who actually cares about the outcomes and let them make the prediction markets and pay attention to them. So the fundamental problem in medicine is to have an actor who actually cares about the outcomes. Prediction markets are just going to estimate outcomes. And if nobody cares about the outcomes, nobody's going to be willing to look at them or pay for them or set them up. That's the problem, is to get anybody who actually cares about outcomes. Now, a lot of people will tell you they care about outcomes, and they're kind of lying. That is, the patients, they just want to trust the system and show that they're loyal to their sacred medicine and not have to think about it, and show that they care by asking for maximal amounts. So they're not very outcome oriented, unfortunately. The patients themselves are not outcome oriented. You might think, say, the insurance companies would be outcome oriented because, hey, if you get a more expensive treatment, they'll have to pay for it. But if on average people need more treatments, then overall their budget goes up. The revenue they're getting from customers goes up. They don't actually want to reduce the overall spending. They might want to have an advantage against a competitor if they could find a way to do something at a lower cost than a competitor. But if that comes at the expense of a reputation for being a cheapskate, that doesn't help the insurance companies. I don't know if you guys remember the HMO revolution of the early 1990s. Maybe you're too young for that. But famously, after the Rand Health Insurance Experiment, a lot of companies heard about those results and they said, hey, we're spending too much on medicine because it's not actually helping our employees. Let's push our employees into HMOs. These are, HMOs are systems where doctors make a lot of discretionary choices about what treatment you can get, and they just won't pay for stuff that they don't approve. And HMOs had been shown through the Rand experiment and other things that it wasn't any worse off. They were spending less and you were just as healthy, so great. And so a lot of firms started pushing HMOs in the late 1980s. And in the very early 1990s, there was a bit of a revolt. People heard rumors that HMOs were saying no to things doctors said yes to, and they took this great offense to this, and they spread rumors about how terrible HMOs were for saying no to things doctors would say yes to. There was a famous movie at the time called As Good as It Gets with Jack Nicholson, I think. And one of the famous scenes in there was a woman not getting full medical treatment for her child, I think, and Jack Nicholson, the hero, comes in and makes sure she gets the treatment, and they both say, those terrible HMOs that wouldn't give us the treatment we needed. And the crowds would cheer at this movie. And this is sort of the story of US medicine, right? Right after the Rand experiment, good data suggesting medicine is not very effective. Corporations deciding to do the cost-effective thing of giving their customers the medicine they need, but not the extra medicine that isn't helpful, by switching them to HMOs, and patients wanting to get everything any doctor would say would be a good idea, and revolting against the HMO revolution and basically ending it at that point. And HMOs backed off and people switched away from HMOs in order to get all the medicine that any doctor says you should get. They rather have the standard of whatever a doctor says could be useful, I want that. And that's the situation still. So the fundamental thing would be to get the healthcare providers to actually care about the outcomes. And then they would use prediction markets in many places. But that's the hard problem. So again, I told you how maybe to do that, merge health and life and disability insurance. But the hard problem there is to convince customers that they, in fact, want to have a mechanism like that, that somewhat distrusts their doctors, that holds their doctors to a financial incentive instead of just doing whatever they say is good. Maybe it'll be some other country in the world, not the US, that first experiments with these. But in some sense, I don't know of anybody experimenting with this yet.
We have some rapid fire questions for you. So the first one comes from Metaculous, and that is, will Robin Hanson win a bet that the GPT line of language models will generate less than $1 billion in customer revenue by 2025? Current community prediction market says 4% chances. The question is, have your views on this topic changed?
Well, I think I will lose that bet, yes. That is, when I made this bet, that was with GPT-3 or something, and GPT-3 was not so impressive. And then 3.5 and 4 were much more impressive, and the world has agreed they are much more impressive. And so the world has gotten a lot more interested in these in the last 6 months for a good reason. And I'm also a lot more interested, and our expectations have risen. So, I made a bad bet.
About 20% of GDP is currently healthcare costs, whereas about 50 years ago, it was a third of that number. Your colleague, Professor Tabarrok's explanation for this is that it is due primarily to the Baumol effect. Do you agree with him? Why or why not?
So the Baumol effect is just about basically service industries versus non-service industries. That is, labor-intensive industries would rise as a fraction of GDP when you don't have high labor productivity improvements. That is, say, playing a violin or something. If you can't get, more people to play, you can't get one person to play 5 violins over time rather than 1 violin, still 1 person per violin, then, and, society's getting richer, then you're just going to have to pay more for that one guy's violin. And so the relative expense of violins compared to other things will just go up. And so the story there is, well, doctors are like violins players. You got to have one doctor sitting in front of you in order to diagnose you. And then, there's just no way to escape that one guy sitting there with you. And that just takes time. And so that means medicine just can't increase in productivity so much. That doesn't seem to me a good main explanation. That is, well, you could have medical assistants or nurse practitioners or other people talking to you. You could have computers talking to you instead of the doctors. There's lots of other things we could be doing instead of having the one doctor talk to you for 10 minutes. I don't think this is intrinsically something you can't use machines to augment. So my explanation would be more in terms of this fundamental luxury good nature of medicine. That is, fundamentally, things you do to signal, you do a larger percentage of your income on those over time because we're getting richer. And so similarly, we spend more on school, which is another main signaling category over time. And that would be my fundamental explanation. Now, it is noteworthy that, say, the rise in spending per capita on medicine jumped around 1955 when there was a big switch to having most people in the US use third-party insurance for medicine. So even though everybody was getting rich up until 1955, and even though medicine was increasing as a fraction of GDP, it was increasing at a slower rate. So it was definitely a jump around 1955. And so that could be plausibly said. Third-party payment made the signaling problem worse. And that's been continuing. Now, this trend has seemed to decline somewhat over the last decade, or maybe that's fluctuations. It's hard to tell. So I'm not sure why exactly that it hasn't increased at the same rate over the last decade that it did over the previous 5 decades. But I guess, yeah, previous 6 decades, really. So that's a big question mark about US medical spending. Will it go back on the previous increase rate or not? And if so, what was the difference? I don't know.
If you had unlimited funds for a single randomized controlled trial, what would you fund?
I would rather fund an experiment on the institutional mechanism for buying medicine. That is, in my mind as an economist, that's the core problem. I want to show people that there's a way to buy medicine under which they could get better treatment for less cost. I'm less interested in showing them the overall effectiveness of medicine and more interested in showing them that they don't have to make this decision. I think it's hard for most people to embrace the idea that medicine isn't very effective because they really want to celebrate it. It's sacred. So I would rather get them to embrace an institution where I say, look, if you adopt this institution, these trustworthy people will make the choice for you. You can trust them to give you the medicine that's valuable and not the medicine that isn't. And let's show in a randomized experiment that that works. That's how I'd like to do it. And in particular, I might even want to change the amounts and see the effect. So I told you that we want to merge health and life insurance, but say I have a value of life of $1 million versus a value of life of $10 or $20 million. If the healthcare provider is on the hook to pay $1 million if I die, they will, do any treatment where another $10 of spending reduces my chance of dying by 1 in 100,000, right? Or another $1,000 of spending reduces my chance of dying by 1 part in 1,000. That would be the threshold at which they would make the trade-off. If a treatment costs more than $1,000 to save me 1,000th chance of dying, they would say, not worth it, too expensive. Whereas somebody who had bought a $10 million life insurance policy through their health provider, that person's willing to spend up to 10 times as much until they say, no, not worth it. So I'd want to not just have some people use this mechanism, other people not. I'd want to do the variation in that amount of money, the value of life for the patient. Like somebody with $1 million value of life or 2 million, another with 20 million, and then see if they actually not only spend less for the people who have the $2 million value of life, actually reduce the mortality rate more for the person who spent more. That would be the ideal to get out of an experiment like that, right? That in fact, putting in 10 times the value on life does produce lower thing. Now, if people were uncomfortable about doing this about humans, because who can put a $2 million value of life, I might be happy to do this for veterinary treatment. Okay, so let's pick a set of wild livestock or something, and we'll get some vets who are going to be paid based on this mortality, effect on, basic life insurance for the cow or the pig or whatever else it is. And then show that if you're willing to pay more per cow, you get, lower cow mortality. That might be my best way to do the first experiment. Just let's do it on animals. And then after that, I'll do it on people. Maybe you do it in India if the US doesn't approve of putting, this sort of, I'll do it whatever you want, but I'd want to prove that there's a way for you to buy medicine where you don't have to disrespect your doctor. You don't have to distrust them. You just hand the decision to them in a way that they have a good incentive, and that's okay. You're not being evil or disrespectful that way. And if I can find a way to do that and give you a randomized experiment with results, then I could show people that this is an acceptable way to buy medicine.
And the last question is, what is one truth that very few of your colleagues agree with you on?
Well, since we're on a medical podcast, I am a cryonics customer. What that means is I have signed up with a cryonics organization such that when medical science gives up on me, I will be frozen in liquid nitrogen. And I will await future medical science to bring me back. My colleagues are not they haven't bought into this yet. One of them, basically, we had a recording podcast once where he just thought it was selfish to try to live and come back again in the future, and not apparently like other medicine. I'm not sure why, but basically, I think it's got at least a few % chance of succeeding, and that's all it really needs to be cost benefit valuable in our world. I don't need a high confidence it'll work. And I think the major risk is the social risk that the institution, tasked with preserving our frozen remains won't last long enough. I mean, I think I'm pretty sure civilization will continue to grow and be more capable. Pretty sure eventually they will be able to take a frozen remains and bring me back as a brain emulation, which is the topic of my first book, The Age of M, Work, Love, and Life, and Robots Rule the Earth. So that's the topic related to medicine that my colleagues probably would disagree with the most. Yes, that it's possible. So if this technology is effective, in some sense, most people don't need to die. That is, the main problem with this technology, there's only 3,000 people who've ever signed up for it. Only 300 ever been frozen since the 60s, when this has gotten free international publicity regularly since then. So you know of the word exactly because it's gotten publicity sometimes. And yet hardly anybody's ever signed up for this. And if you ask students, which I have, like, how many of you think this might work? A large fraction do. So there's a huge obstacle between people who think this plausibly would work and people who actually choose to do it. It's very contrarian. It's very socially disapproved. And so very few people do it. And if a lot more people do it, the cost would just come way down. It's a fixed cost dominated industry. The main problem is there's just a bunch of people who have to know how to do a certain thing and wait around until somebody has it done. And there's just not very many cases because there's so few customers. And that's the problem. So if a lot more people would sign up for this, the cost would come way down, the reliability would go way up, and then basically few people would need to die. So that's a pretty big deal in terms of medicine, if that were true, right? I mean, if most people didn't actually need to die because it would be possible to freeze them and have future medical science revive them, then we are losing a lot of people unnecessarily.
All right.
And I may just have lost a lot of listeners through this revelation. But, honestly, I say, think about what chance do you need this to work for it to be cost effective to you, right? I mean, you don't need basically alternatives. You let worms eat you, or they burn you in an incinerator or something. Take a chance.
Well, Robin, thank you so much for joining us on the External Medicine Podcast. Can you tell people where they can find you on the internet to learn more about you and your work?
I'm lucky that my name brings me at the top of a search engine. So just search for Robin Hanson and you'll find me easy.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution. If you'd like to support us, subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.